So I think that it's really important for migraine providers in the primary care setting to have an understanding about different migraine preventive treatments and at least have some familiarity with being able to start at least one or two different preventive treatments, and those are pharmacologic preventive treatments that I'm referring to. So I think that, for example, the beta blockers, those are level A evidence-based preventive medications. They're already familiar with them in the primary care setting for treating blood pressure issues. Two, there's topiramate, which is also FDA approved level A evidence, and that's also used for treating seizures, so there may be some familiarity with that. And then three, there's even tricyclic antidepressants, which are an older generation. They used to be listed as level A evidence. They're now level B just for various reasons, but just a low dose of that can be really helpful for treating patients. So even just a willingness to be able to try perhaps two different preventive medications, I think, would be really helpful for migraine patients in the primary care setting. And that's actually in combination, I would recommend, with non-pharmacologic treatments. So I think that primary care physicians should be able to have a basic understanding that relaxation therapy, biofeedback, and cognitive behavioral therapy are also all level A evidence-based treatments for preventing migraine. And that studies show that the best treatment is actually a combination of pharmacologic and non-pharmacologic treatment for migraine patients. So I think that there are a lot of opportunities for primary care physicians and neurologists to work together to improve patient care, especially for migraine and for all kinds of neurologic conditions. I think that one, starting at the bottom in terms of working for medical education and helping medical students get this appreciation and more basic understanding in clerkships and even basic science courses, and then starting in residency, adapting it more into residency programs. So for example, in internal medicine programs or even primary care residency programs, having them rotate through not just neurology, but even a headache medicine clinic. And so that might have to involve some telemedicine, it may involve some travel, but I think it's a really integral part for primary care education and sort of having neurologists and headache specialists embrace that idea. And then for attending level physicians, I think that already the American Headache Society has had headache courses for primary care physicians, and they've had like chronic migraine where they've traveled the country, but I think there are even more opportunities. I think that just like we have telestroke, we might need to have some tele-headache medicine opportunities. We also, for example, could have more of an email consultative service. I actually received a grant from the International Headache Academy to research implementing an email consultative service, and I think that's a great opportunity. So I just think that there are a lot of novel ways that we can improve the integration of headache medicine and primary care.